4 great talks. If we could have all the speakers come up and sit at the table. So these were really 4 terrific talks. They were all pretty different, and that was by design. So there should be a lot of questions and a lot of thoughts, and we look forward to comments from the audience. We have one here.
Hello, I'm Sue Schneider with the Oncology Nursing Society, and I also attended the ACS Navigation Roundtable last week. So I heard great programs, wonderful presentations, great perspectives. My question is more related to sustainability. A lot of your programs were NCI grants. I'd like to know what's going on with Karen's program now that the grant is over. I heard another program that was grant funded. There was a philanthropic funded program. Christine, I worry about your program if your enthusiasm goes away. I think you're the glue that holds it all together, it seems like. So, you know, I'm worried that you might be the system fix and, you know, what happens when there's no Christine. So my question is sustainability. Where do you see things going in the future? What does it look like in 5 years if you get it right? And what's happening with the continuation of these programs?
So I'd be happy to start. It's not my program.
Right.
Naming my program, it's the PCCP. So thank you, though, Sue. The first thing is that at the end of the program support from the CMS in 2016, the program at UAB has continued. Several of our partners have also continued their programs as well. And in addition to that, there is a new program, CDC program, that has continued. So we are also still part of that demonstration project that moves on. We're not currently funded by that. How we were able to do that is that we certainly believed in that within our institution. We did have community health advisors. Our CHAs were in the community. We also have a continued patient navigate. We had a history of navigation even before the CMS program began, and so that has been of great value for us, and we have certainly continued that within our organization.
We have some of the other panel members also comment on that.
Sure, of course. So I feel grateful to tell you that there is a lot of investment from Geisinger perspective. So even after the nurses were hired from the NCI grant, excuse me, I've been so sick. Even those nurses were hired, and then we went through a tightening, and a couple of those nurses went away. We had a bit of time where I was in fact it. So I was taking calls from all over the place. But then we came back around, and so then I want to say that, you know, I proved my worth, and so we got some social workers. But the truth is, we have a couple of champions within our system who are willing to take the risk, knowing that the evidence is there, it's just not currently collected. So a physician champion helps. Some champions within the system definitely help for sure.
So with respect to our program, that's why for me it was so important to really look at that ROI, because I think that there's not going to be so much necessarily had been in the past, looking at how do we afford navigators. Again, I think when I look at our organization, I say, how do we not afford navigators, in the sense that we're all in a competitive environment. With respect to philanthropy, I think from my perspective, survivors want to pay it forward. And one of the things that why we set up our peer volunteer program is I was worried about the sustainability. None of the work that I've done is research funded or grant funded. The President's Award that I alluded to was really to look at just basically the breast cancer experience. But what has evolved is this whole then replication of the model that I presented with a nurse entering at the time a suspicious finding. So I think it's going to be a challenge for all of us. I think it's what has been so heartening to me about the past couple days is really to look at the very fact that this work is being done, that does document return on investment, that does look at reduced ED visits, that does look at quality of care, and does look at, you know, those kinds of things I think are incumbent upon us to actually continue that research.
Hi, is this on? Can you all hear me? I don't know if it's turned on or not. Okay. My name is Tina Evans, and I've been a nurse navigator 15, 16 years now. And right now I'm currently working for a very small company that has a nurse navigation documentation platform that's out there. And I think nurse navigators collecting data that we all can use to take a look at metrics and what is happening with patient care is very important. But that's not what I have two questions actually, and one is for Wendy and one is for Cindy, and I tend at times to ask the tough questions that no one else wants to. And Wendy, listening to your talk, and given the fact that navigation seems to be a key part or key in the initiative that you described, I wondered what everyone on the panel or in the room thinks about what is it going to take for nurse navigation services to become reimbursable?
So you're right, that's a tough question, and I'm not sure that I'm going to have an answer for you. What we're trying to do is look at the patient care as a whole, so that patient-centered care, and how do we promote that through these types of programs in the way that Blue plans are working with their providers. How that provider is going to make that change into patient-centered medical, or like more of a patient-centered care, very coordinated care, patient navigation can help that process. Again, I'm not calling out specifically the role of a patient navigator or a nurse navigator. What I was calling out was that concept of navigation, of getting that patient coordinated. So it seems to lend itself towards how they get there. And in order to get there, I think you all, as Chrissy said here, have to prove that you're bringing that benefit to that system, that practice, in order to say, here's how you're going to meet programs such as these, because benefit designs will be wrapped around programs such as I described.
So given that, and Cindy, you talked about ROI and all of the information that has been presented yesterday and today around the value of the navigator versus the navigation process, one and the same. However, the navigator being the driver of that process, it's becoming more and more evident that the value is there and that there are ways to be able to show return on investment. Cindy, you demonstrated that beautifully this morning. And how much more is it going to take before we really begin that push to moving forward the reimbursement of this service? So that's just my soapbox. Then my other questions, Cindy. Oh, and if you'd like to comment on that, that's wonderful.
So,
But
yeah,
you
just-
talked about.
I will give you one comment.
Okay.
A lot of our plans are looking at that care coordination payments to the practices and to the provider groups, provider entity within these programs. So we'll see the S and J, basically S codes they're using in the claims processing in order to provide a care coordination reimbursement to the provider. So that is one way that they can get reimbursed for.
Thanks.
And I have a different perspective on that, kind of the kaleidoscope, if you will, with respect to care. I'll give you a very specific example. I think when you were talking about professional boundaries or scope of practice, I was asked to go into, a very rural area and looked at their breast center in terms of how their workflow was. And I guess I've been Kaizened, or get in the Gemba, as they say. So when I looked at this, I said, well, what's happening? Where's the radiologist? Well, the radiologist gives the diagnosis, calls patients in the evening after she finishes screens or diagnostics. And I said, so where's the nurse navigator? Well, the nurse navigator is starting, this is a breast nurse navigator. She's starting IVs on general radiology patients. I said, well, where is so-and-so? Well, they said they're holding pressure on a biopsy site. So I started to look at it, and when I talk to people, I look at the value of a physician who's using her time to call a patient in the evening when she's tired, and knowing what that impact is going to be for that patient driving home, if you will. Why don't we hire an MA to hold the pressure on the biopsy, get the RN back where the RN should be? So a lot of it has to do with really optimizing the skills and the talents appropriately. And I see that everywhere. I see this nurses doing work that someone else could do, physicians doing work that oftentimes nurses can do, et cetera, et cetera. So I think we're going to have to reevaluate a lot about how we look at cost and efficiency of care.
I couldn't agree with you more. And I think that goes to the idea of standardization of what the role of the nurse navigator, the patient navigator, and get consensus across the country on that. But you were talking about outmigration, and this is it, and then I'll sit down. You were talking about outmigration, and part of the work that I do currently with a small company is looking at capturing metrics. And we do have a way to capture outmigration, but what occurred to me just recently is, how are we capturing and or documenting those patients who would have outmigrated but didn't through the intervention of or the contact with a navigator? And we're not, I don't think, or is anyone, or what are your thoughts around that?
Well,
Those who would leave, we know how much it's costing for those who do leave, or how to figure that out. But what about those who don't leave because of the intervention?
That's why that I was citing that it's a very small sample size because of some other things that were happening with respect to the patients that were with the navigator, you know, what I call bringing a patient in for a safe landing. Saying, you know what, when patients say to me often, when I tell them their diagnosis, they say, well, do I need a second opinion? And I said, you know, I'm happy to help facilitate that, but we have you on the multidisciplinary breast board for next week or 2 days from now or whatever. And I will call you back after that tumor board, and I will tell you what the consensus was for your care. All of a sudden that dissipates, you know, and when they know how difficult it's going to be, particularly because in our area, even though, you know, I'm in the San Francisco Bay Area north of us, there's not a fellowship-trained breast surgeon north of Santa Rosa, which is, as I said, 2 hours away from the Golden Gate Bridge, west of Sacramento, all the way to the Oregon border. So we serve a very northern population as well that's very rural. So when you look at those patients knowing that they can go somewhere and they can have all of their care coordinated within a particular center, that makes a gigantic difference. And frankly, I will never work in a system where if I don't think our system or our particular care center can do the best for that patient. In other words, there's oftentimes that I get calls all the time, and there's a patient with our chief financial officer had a new perspective on navigation when his father was diagnosed with mesothelioma. And the physician, his primary care, wanted him to go to some place, and I was a little worried about that, so we dialogued anyway. Now I'm on speed dial with him. So now when I need that ROI, he's like, oh yes, Cindy, how can I help you? So what my point being is that if I don't think we can serve the patient that is in front of us the best way we can, that patient does need to outmigrate. If we need to send a patient, a pediatric patient for, you know, or somebody for a bone marrow transplant or somebody for a liver transplant, we in our system can do that, but we have to feel comfortable in saying, this is not the best place for this particular patient. Does that make sense?
Perfect sense.
And also what we don't capture is the in-migration, because we do such a good job. How many patients